hello everybody. It's Martin Kiernan here this week, and we're going to be talking about hygiene in low and middle income countries. And my guest today is Assistant Professor Giorgia Gon, who works in the Epidemiology Department at the London School of Hygiene and Tropical Medicine. Giorgia started originally working out on maternal health, but has done an awful lot of work in the field of hygiene, water, safe water, and infection prevention, and has led a recent collaborative that's published a nice report. So, Giorgia, thanks very much for agreeing to chat to me about this.
Thank you very much, Martin, for inviting me. It's really exciting to have this space.
So can we just start up by you saying how this piece of work actually came about, and then we'll talk about the process and sometime in future about the outcome.
So I guess the easy answer is that we've been working for about a decade now with cleaners in several countries, and initially we found a huge gap in training and low skill staff across several facilities across many countries. And one of the pieces that we tried to do was to sort of consolidate the evidence around what's in low-resource settings with regards to environmental cleaning, and possibly understand what interventions people have developed so far to try and address the issues at hand. And what we realized very quickly is that there is a bunch of systematic reviews that look at environmental cleaning available now in the literature, especially in the last 10, 15 years. Mm-hmm. But there is a lack of primary studies from low-resource settings. So all these studies are mostly from high-income countries, or when they are from middle-income countries, they tend to be from quite well-equipped hospitals. Yeah. So they don't really represent the situation for most hospitals, for most people in the world. So we initially embarked in of course, another systematic review to try and really take out the available evidence from low-resource settings. And, not surprisingly, we found very few studies that really focused on low-income settings. Again, poor quality studies or very small scale. Mm-hmm. They might include 1 up to 3 facilities, pilot level studies. So no rigorous evaluations of the interventions. So we're again at the we were back to square one in a way. We knew very well the research gaps. Yeah. But we didn't necessarily know what the priorities there were and how to move forward. So that's how the briefing came about. We're like, okay, so we know that there are gaps in the literature. We know there is still a lot of primary studies to be done. So why don't we bring together people who know a lot about this field from over the world and try and ask them what we think the priorities are. So we did our homework. We found out there's a lot more. But we also, given that it's so patchy, the literature, we also wanted to know directly from experts, what are the priorities going ahead? Especially if we're thinking about the short, medium term, we're not talking about 30, 50 years from now. We're talking about what should we concentrate on now to really make a difference. Given that, again, we're not talking about rocket science, right? We're talking about very implementation research-focused projects that try to make a difference.
I mean, that's the problem, isn't it? When you've got so many gaps, where do you go? How do you prioritize? So, okay, talk to me about then how the collaborative got together and the process that undertook.
We were very lucky to be funded by the UK PHRC team, which is the Public Health Rapid Response Team, which is ultimately funded by UK HSA, which is the governmental agency in the UK. And we had a small pot of money, and that was really helpful because, of course, we're trying to bring people together with some resources. And it was mostly a collaboration between LSHTM, UK PHRC, and Stellenbosch University with Angela Dromowski. And when the idea came about bringing people together, we started in a very organic way, not incredibly systematic, but to try and find among our networks who we thought were the best suited people to build this collaborative. Uh-huh. And of course, some of it is based on published papers and who are the authors of main papers in the field. So in that sense was a little bit systematic. But some of it, because we know a lot of this stuff is not published yet, and there are also people working in this field who don't necessarily are part of the academic world, we kind of branched it out and asked initially the experts we knew, who else should we invite in this collaborative? Who else needs to be part of this conversation? So it was really meant to not just be an academic exercise, It was also meant to include people from international organizations like WHO. So we had representatives from WHO IPCU, Infection Prevention Control Unit, the Antimicrobial Resistance Unit, the Infection Control Africa Network, as well as CDC. So some of the big players which, go beyond the academic exercise per se.
Okay. And the process of prioritization then?
So the process of prioritization was interesting because it was my first attempt to dip my hand to prioritization. And I found out that, of course, like everything you research is a world of its own. And there are lots of ways in which to go down research prioritization. We used some of the sort of more commonly standard methods. In essence, essentially, what we did is that we started from all that literature review that I talked about initially. So really sharing with the collaborative, the clean group, let's call it the clean group because that's what it is. So we shared in group the systematic reviews we found and the findings from our systematic review that again found several gaps. And we also asked, what else are we missing? Are there any key reviews or papers that we're missing here? And so we started from the literature. We're like, okay, this is the literature we know about. These are the gaps. So starting from here, given your expertise, please brainstorm about what you think are the research priorities in this area. And we kind of identified 3-4 themes that kind of helped us structuring our ideas. And these were health system strengthening, because of course, if you really want to implement environmental cleaning at the hospital level, you need to think about all the stakeholders that are involved in that process. So it's not just the cleaner or the orderly or the nurse assistant making the action of surface cleanliness.
Yeah.
We're talking about, making sure there is a budget line there, making sure that there is accountability, making sure that there are policies in place, and making sure someone manages all the process and at all levels of the health system. So there is a health system strengthening kind of component. There is an innovation theme. But of course, we know that, again, we're not talking about necessarily extreme new technology, but there are some things that we still don't know about, like, is it sufficient for low-touch surfaces to be using detergent rather than detergent and disinfectants? Small things like that kind of fall into under the innovation theme. We also identified a theme around behavior change.
Yeah.
Because again, when you have several stakeholders, when you want several people to do several actions, essentially you're talking about behavior change. And this is something that is particularly to my heart because I do a lot of behavioral sciences. And of course, what is the most effective way of training someone that usually comes from a low literacy background or socioeconomic condition? They tend to be women, cleaners in low resource settings. So how can we develop behavior change techniques that support those specific groups to learn and sustain their behavior better in the long term?
Could I just draw you there? Different cultures, of course, would need different techniques. So it's very difficult then to develop a technique that you'll be able to use in all low middle income countries, all low income countries, wouldn't it? What's the challenge there? Because that's very interesting.
So I would challenge that a little bit. So in the behavior change world, you would distinguish between form and function. And without getting too much the details of that, I can say the function would be, I know that there needs to be education. How the form of that education might take place differently in different places.
Okay.
And there are some characteristics that can help you decide, okay, here I need a theater play versus a poster to convey exactly the same piece of information. There are ways that can help you to gather the right information to know if one form would be more feasible than another according to your knowledge of the context. But essentially, the behavior change technique, which is improving knowledge through education, is the same. Okay. So it's essential, as you say. So I think it's really good that you brought that point up, that those things that needs to be contextually grounded and needs to be thought about. You need to think about your target audience, wherever you are.
Right, okay.
Essential thing. It's in fact the recommendation of the briefing. So, yeah.
Now we have a number of different priorities. I think 12 in total.
Yes.
how do you prioritize within the priorities? Because there's still a lot of gaps there, and there's going to be limited funding, unfortunately. As you say, most of the money that goes into this sort of research is in high-income countries, where probably the challenges are somewhat different anyway, and certainly the resources are very different. I mean, can we go forward and think, okay, within the 12, there's still a hierarchy? Because it will cover all the gaps, but there's still only going to be a limited pot of money, isn't there?
Yeah, no, I think that's usually how people think about it. I think that there is a limited pot of money. I think, I would like to challenge that a little bit, in the sense that I think some groups of research and implementation have been incredibly creative at securing funding, right? So I think IPC is not there yet. I think there are other sort of research areas that are much more creative than us at securing funding. So I think that pot can be stretched a little bit more. And personally, I don't think I can make that call, what is more important between the 12 that we identified. I would say that for most of them, when I look at them, like it's hard to really think about something as complex as an environmental cleaning program at the healthcare level without thinking across these domains. So I don't know if I could say, this is more urgent than this. I think we are in a state where funders are interested in different things, and I think we should leverage that. So, if someone is interested in innovation, bring them the innovation question. If someone is interested in behavior change, bring them behavior change questions. So I think it's more about being creative with the way we sell those and make sure we get funded for those. I think it's going to be interesting also, going back to your comment about context, because perhaps the local stakeholders at the political level are also interested in different things. So why don't we leverage that? If someone is more interested in a certain domain, we should support them in trying to do that, because they have ownership of that.
I suppose it would also depend on the actual problem they have in a particular area. If there's something that they then think, well, actually, this is one area that probably we should focus on, like our behavior change or our use of biocides or whatever. So the piece of research may well fit the local context anyway. But you said how complex cleaning is. I think people think cleaning is very easy. And that's one thing that jumps out very nicely from the 12 priorities, in the things that we really just don't know about. And to be honest, I don't think this necessarily applies to low and middle income countries either. I mean, the DPSA has been doing a nice piece of work with a healthcare hygiene assessment framework, showing that actually in very high income countries, there's still significant gaps in the cleaning setup. But you talked about systems though very early on, and how do you think we can actually promote? Have you got any ideas of how we can promote this as something that a healthcare system ought to invest in? Because my problem has always been, if you don't have any data to convince them they have a problem, they're not going to do very much. And we don't have great data in high-income countries. We have reasonable data. In some countries, much better than others. Middle-income countries, not so much. Low-income countries, they'll have no data. So how do we create a problem that somebody needs to solve?
Yeah, I couldn't agree more, Martin. I think that's a big issue. And I think in most low resource settings, we're dealing with situations where you don't have a system of monitoring healthcare associated infections. You don't have a system monitoring environmental, microbiological samples in any way. There is not even routine blood culture of any sort for patients. So how do you make the case that this is a cost-effective?
Absolutely. Yeah.
And I think then that's where research comes in, right? Implementation research, you do a good study to show that it is cost-effective. And then you can extrapolate and say, okay, we cannot do the same study in every single facility. But look, we've done this study in a setting and it's a strong study design. This is applicable to your setting for X, Y, and Z reasons because you have similar profile. So I think that's how we can leverage research to show that cost effectiveness somewhere and bring it to other places. I think the other one, the other thing that we've tried a little bit is to use environmental sampling, because it's much cheaper compared to, let's say, trying to set up a new system of measuring healthcare associated infection.
Yeah.
There are now more and more technologies that are relatively cheap, both to generate, but also to implement in context the lab capacity is limited. Like we've used deep slides a lot which are possible to deploy on surfaces, but also to read from a lab perspective after incubation. So I think I would try and use those sort of very visual, impactful way of showing
That's
people,
what I was
because
thinking.
I mean, no one wants to go to a facility where they know there is high level of contamination, right? Like sit or lie in a bed for days. And then I think you can exploit those data, linking it to very personal stories. I mean, we humans are very persuaded by stories. So I think you can link it to, I don't know, a politician's cousin or, their wife or something. And I think that would really, really strike chord.
Yeah, stories, definitely.
Yeah. Again, I don't think there is a magic... there is no magic wand for that. It's kind of just, trying to see what incentivizes people in that specific context, unfortunately.
I've never worked in countries like this. So would people associate visible uncleanliness with hygiene and infection in the same way that in a high-income country, if you walked into a hospital and there was filth all over the floor, people would be immediately saying, I'm not going in here? Is that linked, and therefore the necessity to make the hospital at least look clean to start with before you start moving down another line? Or do you think people just accept that as the norm and wouldn't necessarily be concerned about something that looks physically unclean in that area?
Yeah, I think the one experience I have with that is actually the power of images in maternity wards. Because actually we found out, and there are now sort of nationally scaled surveys that say specifically the hygiene is one of the women going into deliver in a facility care about. So it is part of their perception, and it's part of something they care about when they choose whether to stay home to delivery or to go to a facility. But in the more small scale studies we've done, we've actually used a lot image evidence to catalyze change in a facility. For example, in India, Bangladesh, we use participatory photography, essentially, to take their own pictures of their environment and discuss with them what they thought the environment should look like. And I think that's very empowering. And those pictures then went all the way up to different stakeholders in the healthcare system. And, I've got in my files plenty of bad pictures, let's put it that way, bad pictures of maternity ward.
We've all got those.
I wouldn't even want to walk into these places.
Okay.
So I think you can use effectively visual evidence for that. And also when we worked with the Ministry of Health of Zanzibar across 37 maternity units, that was one of the most powerful things they took away from our stakeholders workshop. Much more than all the data that we showed them was the pictures that we showed them. Having said that, I also know, because we've tried to do a comparison between our microbiology data and the pictures, and in reality, there is actually very little, match between the two. So I think I would always use it carefully.
Yes. Okay. Is there a frustration amongst cleaning staff from your work that they can't do as good a job as they would want to do?
Yeah.
Or, because certainly that's been my experience of cleaning staff here in the UK. I go to give them a lecture. I spend the first 20 minutes telling me, I can't do this, I can't do that, I can't do that. So they really do want to do a good job. Is that a similar experience that you've had with cleaning staff? There's some frustration that they aren't able to do better than they can with what they have, but they don't have the power to be able to ask for equipment or whatever they need, what resource they need?
Yeah, I think definitely the lack of resources in many of these settings is really, really a challenge for cleaners. They just don't have enough mops, they don't have enough cloth, they have to use the same cloth, and it's all reusable equipment. So not only they have to spend a huge amount of time cleaning, but they also have to spend a huge amount repurposing these equipment for the next day. And I think that's definitely a source of frustration. I think another feeling that I come across a lot, but that's because of the different context, is that these cleaners often, when we first work with them, they've never received formal training, never. Right. So they're used. The standard thing that I hear is, we clean the hospital like we clean our own home. So there is no sense of this is a specific place where you clean a certain way with a certain technique. And the amount of good feedback that we got from implementing, probably you came across the latest WHO training for low resource settings around environmental cleaning, which kind of stems from the Teach Clean training manual that the Soapbox Collaborative team developed. So I was lucky enough to kind of evaluate that training, and now it's great that WHO took it over. But essentially, it's amazing because many of the countries where we piloted this training, the feedback was consistently, they were so happy to first finally be engaged in an activity of any sort in terms of formal training. And first of all, to learn actually how to do their job properly. Yeah. So actually an increasing satisfaction from being able to perform, and at the same time, facing the problem of, actually your workload goes up a huge amount because do things properly, and you have the same amount of hours you're paid for as before the training. So in that sense, that's where the frustration came from again. So the happiness about being taught and being skilled finally with, I still have 4 hours in my day to do all these things, and now the time I take to actually do a proper technique is double than what I did before. So that's sort of
I can imagine. Yeah, I mean, when you've done a study like that, were you able then to convince the healthcare system that they actually need to maintain that training, that they're going to get a positive benefit out of it, or did they just see it as a piece of research and that's really nothing to do with us going forward?
I think that changed country by country. So really depending on the context. Like, for example, when it works in Tanzania, they had a quality improvement system, the 5 S's, if I'm not wrong, one of which was surface. So they already had it in their realm, even though there was no formal training on the ground. So it was easier for some of these things to be part of the continued quality improvement system. There are other countries where you're starting from scratch. There is nothing around cleaning. Like, for example, we had an incredible experience now in Cambodia across 13 of their major referral hospitals across the country. And they didn't have anything in their policies around environmental cleaning, anything consistent. So they're actually going to use the WHO environmental cleaning training to be part now of the national infection prevention control policy. But that took, this is like a 3.5 years project. So,
because healthcare managers may want to allow time for cleaning, but they've got to feel they need to do it in order to be able to create the time, don't they? And then, you've got to backfill somebody while they're taking time off to clean. So I was just wondering about, did the research convince them that actually they need to do it rather than just wanting to do it?
Yeah, I think I'm not sure about that, to be honest with you.
Okay.
I hear more of the practical struggles with, I don't have room in my budget. I can't hire more people. Lots of issues with contracted out services. So, for example, in the situation of Cambodia, you will have some local cleaners that are hired locally. They're not part of the staff members. They have 4 hours in a day, 2-3 cleaners for 60 beds. I mean, what are you going to, how can you make a realistic cleaning schedule to match that human resources?
Yeah.
And that's where the manager and the champions that we selected to kind of support that process are stuck, because they feel like, how much can I ask of my staff? Well, I'm worried that they're going to quit. And that's a concern. We have to kind of work at all levels until all levels kind of sing a bit like a Swiss cheese,
Swiss cheese, yeah.
All the holes need to line up for it to kind of become easy.
Okay. Yeah. Okay. Well, thanks very much, Giorgia. It's been fascinating. We'll put a link to the full report on the podcast site, and I know you've got publications that are likely to come out from this in the not too distant future. But I think it makes a fascinating read, to be honest, and I just wonder where to start, really. But as you say, different people will pick off different areas, perhaps, and pick off the local priorities. So thank you very much for giving me your time. I really appreciate it. Thank you.
Thank you so much, Martin, for giving me this opportunity.
Bye, everybody.